is pathways towards universal health care. And of course, single payer is one way, but there are others. We explored some of these with Andy Beinman and Anthony Wright in a special Capital Insights program in the fall. And today we pick up on that theme again. And in doing so, I'm pleased to introduce our two guests from UC Berkeley Center for Labor Research and Education. Speaking first will be Miranda Dietz, who is Research and Policy Associate at the Center. She's also Project Director of the California Simulation of Insurance Markets Microsimulation Model, or CalSIM, that's a mouthful, which models the impact of various policies on health insurance coverage in California. Ms. Dietz has a BA in government from Harvard and earned a master's in public policy at UC Berkeley. She's the author of numerous reports and white papers, and she was co-editor with Michael Reich and Ken Jacobs, both of whom have spoken here at the center before on this platform, of the book, When Mandates Work, Raising Labor Standards at the Local Level. Her remarks will be followed by Laurel Lucia. Laurel is director of the healthcare program at the Labor Center at UC Berkeley. She has a BA from Stanford and also a master's in public policy from UC Berkeley. Prior to coming to Cal, she was a senior researcher at the SEIU, and before that was a senior healthcare analyst at Kaiser Permanente. She also is the author of dozens of white papers and op-eds on Medicaid, health insurance for immigrants, covering the uninsured, and numerous other topics. So it's a pleasure to have both of you here today to talk with us about this important topic of moving towards universal health coverage in California. Thank you.
Thanks so much for the invitation. It's a pleasure to be here. So I'm Miranda Dietz, and I'm going to start us off here talking about California's remaining health coverage gaps, the causes, and the state solutions. So I'm going to talk first about the who and the how many, and then I'll turn it over to Laurel, who will talk about the why and the what we can do. First, to just take a step back for a second, why are we worried about people being uninsured? We're worried about it because health insurance really matters. It matters for individuals, for financial reasons, and for health reasons. People expect that health insurance will, and research bears out that health insurance will, help protect people from financial distress. It encourages folks to get an earlier diagnosis and improves the use of preventive services, and it reduces preventable mortality. So health insurance is really important for the individual people who need it, but it's also important for the kind of society we want to live in and what we want our state to look like. So what do we want everyone to have access to? The people we interact with at school and at work, when we go to church, when we go shopping. So because we care about health insurance and getting people covered, the Affordable Care Act expanded access to health insurance. It did that by expanding Medi-Cal, largely to the childless adult population, by providing premium subsidies, by providing premium subsidies and out-of-pocket subsidies for folks with moderate incomes, and by banning exclusions due to pre-existing conditions. The ACA also offered other consumer protections, but it did leave out some important groups. It left out the undocumented. It left out people who earn too much for ACA subsidies. That threshold is currently 400% of the federal poverty level. And it didn't really provide enough affordability help for some of the folks who are eligible for those subsidies. So that's what the ACA did, and California did a really good job implementing it. What you can see here is the drop in the uninsurance rate in California for the non-elderly population. It went from about 18% to just over 10% during the period of time when the ACA was implemented. But we're still at 10.4% of folks being uninsured in 2016, which in researcher land is today. And 10.4% equates to about 3.5 million Californians who lack insurance. That 10.4% might be a little bit higher than the number that you're used to seeing from some other sources, and that's for a couple reasons. One is that we're just looking at the population aged 0 to 64. We're not talking about the 65 plus population because their coverage didn't change very much as a result of the ACA. They're mostly covered by Medicare. The other reason this number might look a little different is that we're not including among the insured people who have only restricted scope Medi-Cal. So that's primarily undocumented folks who are only eligible for emergency and pregnancy services in Medi-Cal. So this is what California achieved by implementing the ACA really well and staving off the Trump sabotage as much as possible. But despite the good job that California did, ACA didn't get us to universal coverage. And we're worried that this progress could erode if the state doesn't take action, and we'll talk about why. So when we talk about the future, how do we get our numbers? How are we predicting the future? We're using CalSIM, the California Simulation of Insurance Markets, which is a joint project between our center, the Labor Center, and the UCLA Center for Health Policy Research, with some generous support that we'd like to appreciate from Covered California, California Healthcare Foundation, the California Endowment, and the California Wellness Foundation. And what this is a micro-simulation model that models individuals and firms' decisions under various policy scenarios. I'm not going to go into a big methodology discussion, but I do want to give you just a picture of what we do in CalSIM, how we get these numbers, and explain what a micro-simulation model is briefly. So a micro-simulation model is taking a bunch of individuals and figuring out for that individual person, that individual record, with all of their attributes, what would their decision be, given all their unique circumstances? What would their decision be in a certain policy scenario? So first, we need to create that data set of individuals. We start out with two different data sources. One is the Medical Expenditure Panel Survey. That tells us about people and what they spend on healthcare. And then we also have information on California firms from EDD and from the California Employer Health Benefits Survey. So what firms offer insurance and how generous is it? We combine those, we put workers into firms, and then we get a bunch of families with individuals where the workers are part of particular firms. But then we want to make sure that it really looks like California. So for that, we use the California Health Interview Survey. And we reweight things to make it really look like California, including we model the undocumented population. And then we get our CalSIM input data set. What we do next is model the firm decisions and the family decisions. So there's individual behavior, given a set of different things that each person is eligible for. What do they pick? And there's firm behavior. Given all the people in my firm, do I choose to continue offering health insurance? Do I add? Do I drop? Do I, the firm? Those obviously interact, whether or not you have an offer from your employer or not. And what we end up with is this data set that says who took up what coverage, who's in employer coverage, who's in Medi-Cal, who's in the individual market, which means folks in Covered California or buying directly from insurers, and who's uninsured. And what are all the demographic characteristics of those people in each of those categories? So that's just the picture of what CalSIM does. The type of thing we do with CalSIM is model different policies. So one of the important policies that we've modeled is getting rid of the individual mandate penalty. Part of the ACA was that you have to have health insurance. If you don't have health insurance, you can either claim an exemption if you're undocumented, if you don't make enough money to file your taxes, if you don't have an affordable offer, you're exempt from paying that penalty, or you have to pay the penalty. But effective in the 2019 tax year, Congress got rid of that penalty, made it zero, as part of the tax bill that Congress passed. So what does that mean for California and who's going to enroll in coverage? We think the mandate had an effect on how many people purchased coverage and how many people were enrolled. So what's it going to mean that that's going away? Big picture, what it means is that 500 to 800,000 more Californians will be uninsured because the penalty goes away by the time we get to 2023. Why am I talking about 2023? I thought this went away in 2019. So I'm talking about 2023 because we think that it takes some time for this effect of the penalty going away to really show up in the numbers. So some people, when the penalty goes away, they immediately don't keep paying their premiums, or they drop coverage, or they don't renew. There's sort of some immediate effect. But polling shows that not everybody knows about the penalty going away. Some people won't find out until tax time this year or next year. And then there's some of this effect that's a result of churn. People churn in and out of coverage, they might lose a job, and if the penalty had been there, they'd have the extra encouragement to shop for coverage, enroll in coverage, purchase coverage. Without that penalty, that extra nudge to sort of go through the door and shop and look for coverage, fewer people will enroll. So that's sort of the mechanism of how the penalty works. The other thing you might notice about this slide is that it's got ranges on it, and that's because there's considerable uncertainty about the effect of the penalty. The penalty went into effect at the same time that the premium subsidies did and all the other sort of benefits of the ACA, so teasing out what was due to the penalty versus what was due to premium subsidies is difficult. We're not totally sure about the exact size of the effect here, so we're giving ranges. To look at the individual rows here, these are the different insurance markets that exist in California that will be affected. So there's the individual market at the top where the impact is the biggest. These are folks in covered California or buying directly from insurers. And here you can see 200,000 to 300,000 fewer in 2020, increasing to 300,000 to 400,000 fewer by 2023. And there's sort of two effects going on here in the individual market. One is that some people drop their coverage because the penalty goes away. But because those people who are sort of most likely to drop are likely to be slightly healthier than the folks who stay, what's called the risk mix of the individual market gets worse and premiums go up. We estimate that by 2023, those premium increases will be 8 to 10%. So particularly for the individual market where people don't get subsidies and are paying the full cost themselves, they've got that extra cost that will result in even more people leaving the individual market. So that's the change in the individual market. There's also some change that we anticipate in Medi-Cal. This is mostly due to people not shopping for coverage when they churn in and out of being eligible for Medi-Cal, because most people in Medi-Cal aren't actually subject to the penalty. But that sort of not shopping effect has a pretty big impact on the numbers. By 2023, we're projecting that 300,000 to 400,000 fewer people would be enrolled in Medi-Cal. And then for employer-sponsored coverage, it's a little bit complicated the way our model works and the effect there. And I'm happy to talk about it more with folks who are interested. But suffice it to say, for this is essentially no change in the individual market. In the employer-sponsored insurance market, which is about 17 million people in California. So in the context of 17 million people, a change of a few, 50 to 100,000 people is quite small. But overall, when you add these up, getting rid of the individual mandate penalty, we project will increase the number of uninsured by 500,000 to 800,000 by 2023. We can also look at the change due to getting rid of the individual mandate penalty in terms of the change of enrollment, the share of each market. And this is where you can see that the biggest impact is really in the individual market. So there you can see a drop of 10 to 14%. In Medi-Cal, the numbers were also big, but because Medi-Cal is a much bigger program, as a share of the program, it's a smaller percentage. And this is where you can see that in the employer market, it's a change of less than 1%. So what does this mean for the overall uninsured rate in California? We saw before that the ACA, as implemented in California, resulted in this big decline in the uninsurance rate, but we're worried that this progress will start to erode and uninsurance will start creeping back up if there's no state action taken. And the majority of this change is because of the individual mandate penalty going away. So the uninsurance rate for the non-elderly population in California, we project will reach 12, 13% by 2023. And that equates to more than 4 million Californians who won't have health insurance. So these are projections, and there's a couple important caveats about what we're not modeling. We're not modeling changes to the economy. So there could be a recession, and that would have a big impact on the number of uninsured in California. Not part of CalSIM. The second thing that we're not modeling are there's some other policies that could really impact insurance, namely the proposed rule on public charge. So this is all about enrollment in which public programs would count against someone who's applying for a green card or a visa. And healthcare and enrollment in Medicaid has traditionally not been one of those programs that counted, but the Trump administration is proposing that it should be. If this rule went into effect, it would only affect a relatively small share of the immigrant population, but even the proposal, and certainly if the rule were adopted, it could have a significant chilling effect on all immigrants and their families in California and their enrollment in public programs. So this is a big deal, but we're not modeling it in CalSIM. For some more good analysis on this issue, I point you to a fact sheet from Laurel and colleagues at UCLA that talks more about the impact of public charge in California. So if we want to understand the uninsured population, we want to have the trend go in the other direction, we want to be working towards universal coverage, we need to understand who the uninsured are. And in some ways, they look pretty similar to the rest of the population. So it's not that all of the uninsured are in excellent health. They look pretty similar to the rest of the population in terms of the share that are in good, very good, or excellent health, and the share that are in either fair or poor health. Most of the adults are either working or in working families. But there are some important ways in which the uninsured population looks different from the general California population. They're more likely to be Latino, and they're more likely to be low income, which we're defining here as under 200% of federal poverty. To understand even more about this population, we can look at what they're eligible for, and CalSIM helps us do that. So of the 4 million people who are projected to be uninsured unless the state takes action, the largest group are undocumented folks. So that's about 1.5 million of the uninsured in California. There's about another million who we project are eligible for Medi-Cal but uninsured. About 500,000 who could be getting subsidies. Another 500,000 who earn too much to qualify for subsidies. They're above that 400% FPL line. And then just over 500,000 who have an offer from their employer but don't take it up and remain uninsured. So this is our picture of the uninsured and those 4 million people in California. And now I'll turn it over to Laurel, who'll talk a little bit more about why we think people are remaining uninsured.
Good afternoon. In this next section, I'll describe the two biggest reasons that Californians continue to lack insurance: exclusion due to immigration status and difficulty affording private insurance. So to start with Californians who are undocumented and uninsured, as Miranda mentioned, undocumented adults make up the biggest group of uninsured. But in 2016, California expanded Medi-Cal to all low-income children, regardless of immigration status. Therefore, now a lot of the focus in the policy discussions is around undocumented adults. Almost 2/3 of undocumented adults have income that would qualify them for Medi-Cal. And so a lot of the discussion now is specifically around expanding Medi-Cal to low-income undocumented adults. And low-income or undocumented adults who are low-income have an especially high rate of uninsurance, a 90% uninsurance rate. That's compared to a 10% uninsurance rate for citizens and Californians with documentation who are of the same income level. This is based on analysis by Nadi Parat at UCLA using the California Health Interview Survey. The uninsurance rate for low-income undocumented adults is especially high for a few reasons. First, they're excluded from full Medi-Cal benefits under federal policy, although California has offered eligibility for full Medi-Cal benefits to young adults who have DACA using state funds. Undocumented Californians are not eligible to purchase insurance through Covered California, even without subsidies, and that's also due to federal policy. Although undocumented Californians can purchase insurance directly through an insurer, but without subsidies, the premiums are out of reach for many due to their income. And then undocumented workers are less likely than other workers to have job-based coverage because they tend to work in industries and occupations where they're less likely to get an offer. So turning to the next biggest reason for uninsurance in the state, affordability concerns. Survey data shows that cost is the top reason that people who are eligible for Covered California but remain uninsured continue to lack insurance. And that's true regardless of what income level you look at. Last March, we did a study looking at all of the evidence and data around the concerns that Californians have in affording individual market insurance. And so this is a picture of the report, and we go pretty in depth there. Today, I'll just touch on a few of the key points from that study. So it's both those who are already eligible for Affordable Care Act subsidies and those who aren't that face challenges affording premiums and out-of-pocket costs. For those who are eligible for Affordable Care Act subsidies, for those with typical health use, combined premium and out-of-pocket costs can still exceed 10% of income for many people. For those with very high healthcare use, who have chronic conditions or other healthcare needs, they can still spend 20 to 30% of their income even after Affordable Care Act subsidies. For people who earn too much to qualify for Affordable Care Act subsidies, or more than $48,000 for a single person, or about $98,000 for a family of four, some of the people in this group face premiums that can equal more than 20% of their income. And that's before out-of-pocket costs. That's to purchase a bronze plan that has a $6,300 annual deductible. So to get a little bit more specific about these two different groups, first, here are some examples of people who are already eligible for Affordable Care Act subsidies but may continue to struggle to afford premiums. So what this graph shows is going across the bottom, that's the income level as a percentage of the federal poverty level, up to 400% where the subsidies cut off. And it shows what percent of income people are required to pay on their premiums. So at the lowest income levels, people pay no more than 2% of their income after subsidies. At the highest income levels on this scale, they pay no more than about 9.5% of income. So this first example, someone earning $30,000 a year would pay $200 a month in premiums. And $200 a month when you're earning, I had the number, could be a lot depending on how much you're paying for rent and other basic expenses. A lot of people at that income level won't have enough left over to pay for premiums. And part of the reason for this is that the Affordable Care Act does not adjust subsidies based on cost of living. And so this is particularly an issue in California, and especially in high-cost parts of the state. In the second example at the top, a family of 4 earning $86,000 a year, or $7,000 a month, would have to pay $700 in premiums. And again, depending on the specific circumstances this family is facing, that premium amount could be tough to manage. So this is a hypothetical example of a couple that earns too much to qualify for subsidies. They're both age 55, both self-employed, living in San Mateo in the Bay Area, and earning a little over $70,000 a year. This couple would pay $1,200 a month on their premiums, and that's for the lowest cost bronze plan offered. And so they'd be paying more than 20% of income on premiums before any out-of-pocket spending. So bronze plans do cover some out-of-pocket or some outpatient care with a copayment, but most services are subject to a $6,300 deductible, and that's per person. So if both of these adults had a lot of healthcare needs, they could both pay up to $6,300 each in out-of-pocket costs. And research has shown that when out-of-pocket costs are too high relative to income, people skip or delay care, including necessary care, and also face financial difficulties. And so a lot of our presentation today focuses on the uninsured, but it's also important that policies consider underinsurance, which means having insurance that doesn't provide adequate financial protection from out-of-pocket costs. And the Commonwealth Fund estimates that 1 out of 5 Californians with insurance is underinsured. So it's not just about how much is provided in subsidies or is not provided in subsidies that drives affordability concerns. Of course, the underlying costs of healthcare have a big effect on how affordable healthcare is. And rapidly growing healthcare costs are not just a problem in the individual market, but also for many of the people who get coverage through their job, which is still more than half of Californians. So this graph shows how rapidly premiums have grown for people with family coverage through an employer. Over the last 15 years, premiums have grown 6 times faster than inflation. And as a result, workers and employers are struggling to afford premiums, and also, in some cases, out-of-pocket costs. Even though the average benefit levels for job-based coverage are higher than in the individual market, more and more workers with job-based coverage are facing high deductibles each year. And not only does the rising cost of healthcare affect how much people pay for healthcare, but in the case of job-based coverage, rising healthcare costs have also been a contributing factor to stagnating wages. So for all of these reasons, addressing the growth in underlying costs is an important component of getting to universal healthcare. So now I'm going to talk through some of the options the state has in making coverage more universal and controlling costs. And I'm going to cover a lot of ground, so I'll just touch briefly on each. First, as many of you in this room know, other countries have more universal healthcare systems than we do in the US, and they often get more while paying less. So this is a graph from the Commonwealth Fund that shows that the US spends more on healthcare and has lower health system performance compared to certain European countries and Australia and Canada. So there's a lot of interest right now in fundamentally redesigning our healthcare system. In order to do that, I think most people agree that we would need to maintain the federal dollars that we currently get through Medicaid, Medicare, and the Affordable Care Act. And that would require federal approval, which would be difficult to get under a Trump administration. But Governor Newsom recently proposed steps that he wants to take to try to lay the groundwork for an easier federal approval process when we do have a friendlier administration. And also the legislature and Governor Brown last year established in law a new council that would start this year. It's called the Council on Healthcare Delivery Systems. And this council is required to develop a plan that would include options for advancing progress toward achieving a healthcare delivery system in California that provides coverage and access through a unified financing system for all Californians. And so this could be a single payer system, or it could be another system that would bring every Californian under the same program, but may still include a role for insurers. So while the state considers these longer-term options and seeks federal approval, there are steps that the state can take in the near term to get closer to universal coverage and control costs that would not require federal approval. So I'm going to talk about each of these, but just to give you a preview, expanding Medi-Cal to low-income adults, including the undocumented, providing state subsidies to improve covered California affordability, establishing a state individual mandate penalty, supporting outreach and enrollment efforts to help people enroll, and then also implementing state policies that help to control costs. So over 950,000 undocumented adults are already enrolled in restricted scope Medi-Cal, which primarily provides emergency and pregnancy-related services. And these adults could be automatically transitioned to full Medi-Cal benefits if the state decided to expand eligibility and make the investment using state funds. This was how it was done when undocumented children became eligible for Medi-Cal. The Legislative Analyst's Office estimates that more than 1 million undocumented adults would enroll under such an expansion at a state cost of approximately $3 billion. And the governor this month proposed spending $200 million to cover 138,000 undocumented young adults. And we are currently finishing up a report that we'll be releasing in the next couple of weeks on this topic with our own estimates and some additional context around this policy proposal. So the state could also play a role in making individual market insurance more affordable by providing additional premium and out-of-pocket subsidies to folks who are already eligible for ACA subsidies, and could also cap premium contributions for those who earn too much to be eligible for Affordable Care Act subsidies. And there are many different variations that could be implemented here. Covered California convened a work group this fall and winter to look at those different state options, and this is a process required by the legislature, and they'll be making a report within the next week to the legislature with some options and cost and enrollment estimates. And so their preliminary estimates looked at a range of options that would cost anywhere from less than $500 million to over $2 billion a year. The governor's budget allocated approximately $500 million to improve covered California affordability. So California could also consider implementing its own state individual mandate now that the federal penalty has gone away. The governor's budget proposed to do exactly this and proposed modeling the state penalty after the federal policy, and estimated that that would bring in about $500 million in revenues that could then be used to fund the affordability improvements. Massachusetts has had its own state mandate for many years. New Jersey, Vermont, and the District of Columbia recently passed their own state mandates that are either being implemented this year or next. And so this is another option the state can consider. Oops, sorry, I didn't realize. California's been a leader among states in terms of doing advertising and helping people enroll to ensure strong enrollment levels in both Medi-Cal and Covered California. And these kinds of efforts will continue to be critical, especially without a penalty as that nudge to get people to enroll in coverage, and especially if the Trump public charge rule gets implemented, there will be a lot of effort needed to help people understand the implications of that and to continue to maximize enrollment. There are also a number of steps that the state could take to help to control rising healthcare costs. And this could certainly be its own lunchtime presentation in itself, so I'm only going to touch briefly on it. But as I previously described, rapid cost growth is very much intertwined with the affordability problems we have. So to address this, the state could consider policies like stronger antitrust enforcement, prohibiting certain anti-competitive practices among providers, improving transparency in healthcare, increasing negotiating leverage for public and private purchasers. Governor Newsom has a proposal around, and an executive order around drug costs that falls into this area. California could strengthen its review of insurance rates and also consider regulating provider prices. So this is by no means a comprehensive list, and I think you could have a lot of, if you had a bunch of health policy experts up here, they'd all present different lists. I think mine is more focused on policies that would help to control prices rather than utilization, since that seems to be a bigger driver of the cost growth at this moment. But this is just to give you a flavor of what I mean when I say state policies to control costs. So to sum up, if the state doesn't take any further action, we're projecting that more than 4 million Californians could remain uninsured by 2020. Undocumented residents continue to be the largest group of uninsured. Affordability concerns persist and are a big part of the reason for uninsurance continuing. And over the long term, the state is and should look at ways to overhaul our healthcare system in deep ways, like whether it's through a single payer system or other unified financing approach. But in the short term, there are steps the state can take that don't require federal approval, like expanding Medi-Cal to undocumented adults, providing state subsidies to improve affordability, implementing a state individual mandate penalty, supporting outreach and enrollment efforts, and adopting policies that help to control cost growth. So we've just provided a few links here to some of our recent publications on the uninsured, on the public charge rule, on Covered California affordability, and stay tuned on our website for our upcoming report on expanding Medi-Cal to undocumented residents. And we look forward to your questions.